Are we ready to get started?
Yeah, go ahead. Cape Girardeau's running into some technical difficulties, so they may be a little bit late, but you can go ahead and get started.
Okay. Hi, everybody. I'm Carissa Vandenberg. I'm over at the SLU AHEC office. I'm a professor of family and community medicine. One of the things I do is I'm deputy director of the Area Health Education Center. And I have to warn you, I have a therapy cat in my office and it'll meow every once in a while. Another thing, my background is as a social worker who works in the community and who has done a lot of community development work, a lot of projects, community organizing, things like that. So this talk is really about, because I know a lot of people come to the health profession, they start seeing problems in their patients and they say, okay, I want to do something. And this is sort of a step back and to basically understand what that means. So the purpose of this talk is to provide scholars an understanding of why it is important to advocate towards changing social determinants of health. It is also to provide scholars with strategies for how community practitioners assess the needs for change in the community. People who work in communities don't just come in, or they shouldn't come in with an idea of what they want to happen and expect people in the community just to go along with it. You have to get buy-in, and you have to also really get a sense of what the needs are and why people are behaving the way they're behaving. Another thing that this talk is going to do is focus on providing scholars with strategies for how community practitioners use data to make changes in the community. So start. I don't know if anyone has seen this map. This is a life expectancy map that was created by CDC. They had done a very large study called the United States Life Expectancy Estimation Project. And it showed that race and income strongly influenced life expectancy. And we see that really specifically in those areas that have higher rates of more African Americans and that have lower incomes. So we really see that if you're looking at, if you're looking at this map, you really see that these darker areas is where these darker areas is where life expectancy starts to reduce, and those are also poor areas of the country. U.S. life expectancy gains have not kept pace with other first world countries. If you look at this graph, you really see that in the 60s, we were ranked number 3 in life expectancy. And among the 10 major countries, we started to fall to number 10 by 2016. So what's going on there? One thing is this does split off by gender. Women are now lower in their counterparts than other high income countries. And this is especially stark with women. So this really becomes an issue with women's health. And this pattern really started to change in the 1980s. Life expectancy gap in the US and other countries is also surprising because the US spends more of its domestic product than any other country in the world on healthcare. So again, what is going on here? So one characteristic of the US system that distinguishes it from other systems is that it doesn't have any kind of mechanism for universal coverage. The percentage of people who have been uninsured in this country has hovered around 16 to 18%. It has reduced with the Affordable Care Act. It went to about 10%. I think it's at 13% now. There's problems also with affordability of healthcare. And one of the problems is that the healthcare system is not particularly efficient. So a lot of the money is used to basically treat major diseases, and they're very good at treating once it's detected that you have a chronic disease. But this is very, very expensive. They're not good at early detection. They're not good at figuring out how to reduce risk factors for these health conditions. They've also made some strides in some behaviors. We've seen that smoking has reduced. Now we have about 20% of people who smoke, although this is a pretty stubborn percentage of the population. It is very difficult to get them to quit. Meanwhile, the obesity rates have really started increasing significantly. We also have other issues in the US. There's people are working more. A lot of times people have to get more than one job to survive because the incomes are not as high as they need to be to have enough for housing and other basic needs. This creates a lot of stress, which also does affect your health. So, I mean, I think everybody has heard what the social determinants of health. I mean, this is what brings us to these social determinants. These are conditions in which people are born, grow, work, and age. Their circumstances shaped by distribution of money, power, resources at local levels, and they're responsible for health inequalities. They essentially, what is unfair and unavoidable differences in health statuses between these communities. We are beginning to learn that a lot of the things that you're learning in the Scholars Program, like when you integrate medical and mental health services, or you do interprofessional care where you have medical services and social services combined, a lot of these have been found to be very effective. In fact, if you combine medical and social services together, you are 10 times more effective in meeting social needs that are related to health outcomes. So in terms of, figuring out how we start creating health centers that actually are able to target social needs. How does that happen? Well, whenever social programs are established, there is a process in which they're established. There's basically a period in which the people who are trying to design the program will listen to community's input. And that means different types of stakeholders. There's definitely, the patient stakeholders, but there's also people in the community who know a lot about what's going on, but who also have control over resources and also regulate and other things like that. So one of the ways that you basically get the community's input is through a community needs assessment. So first, we'll take a couple steps back. Community, what do we mean by community? Community is a group of people. They're linked by social ties that they share, and they share a common perspective or interest. So they may not all be residents of this community, but they have an interest in that specific community. I mean, so in terms of a health center, not everybody will be living right on the periphery of that health center, but they may be patients of that health center. They may be people who are working in that health center. They may be an organization that partners with that health center to get healthcare for their own clients. By needs, we are referring to needs for better health, concerns of community members in the health system in terms of improving health outcomes. There may be other needs, but if we're looking at our own healthcare organizations, that's what we're really focusing on. So a community needs assessment essentially is a process in which community members gain understanding of what they need. They gain an understanding through identifying, collecting, and dissemination of info on assets and needs of the community. So why do we do this? Why does a community assessment happen? Well, when we want to make change in a community, we do it usually through trying to get a policy change or trying to establish some type of program or intervention. So in the case of creating a program intervention, this requires a planning process and a well thought out plan of action. You need to know what you can do and what you can't do in a community. Now remember, you are often coming to this community as an outsider who does not live there. You need to know the constraints and opportunities within the community in order to be effective. When you do this, you also want to find funds to ensure the program is sustainable. And you can have a more realistic implementation plan and also have a more effective program when you've had this engagement process take place. What are some other reasons that we do community assessments? One is we identify and set priorities based on need. We make decisions about how to improve the community and organizations based on the needs and available resources. Again, it allows us to kind of figure out what our priorities are. And then when we kind of go through those different priorities, what is the ultimate goal of doing this intervention? What's the ultimate goal of creating a new policy? And also we need to understand, we need to be able to operationalize our outcomes and provide standards of where we want to go. Well, what do we want changed and how are we going to measure that? Other reasons. It's when we start wandering around the community, asking people questions, we learn about other organizations and agencies that are doing things in the community that can help us out. We also get a much better understanding of why people are coming with this certain condition in this community, why people end up getting higher rates of cancer. And that makes it easier for us to figure out how to intervene. It also basically provides a very good public relations tool for our different healthcare agencies. So when we can publish our needs assessment as reports, and it shows that we are working on the problem, that we are aware of what's going on with our patients, and that we are part of the solution. And yes, there's even more. So other benefits, strengthen community involvement. So when you're talking to people and asking them about this, they become involved in a lot of them want to be helping you out with actually establishing whatever the intervention is that gets agreed upon. It's really good use of resources. Having yourself start doing a little of the needs assessment or leading it and working with community health workers, they're basically really good at connecting with the community. They save a lot of money because they don't have us waste a lot of our time. They improve communication with the public, improves data quality, and it sustains health initiatives. Even when we are not able to keep them funded, people figure out a way to keep it. This isn't to say that this is something that everybody always welcomes. When you do community work, you'll find that there is a whole lot of hustle involved because you're asking people to do things for you. And that may mean that people have to give something up. And, we see this when people tend to get territorial about their funding. People get territorial about their staff. People get territorial about their data and willingness to share information. And all these issues come up. In this way, it becomes really important that you're able to communicate very well and very effectively with people and recognize that you're asking them to do things for you. There, across these different organizations, we have, if you're working with a healthcare organization and a social service organization, or maybe like a church, people have different languages. They don't necessarily speak the same way, and they have different goals. And so you have to coordinate those. Sometimes it's difficult to find data to your area. It may not be available. Some populations are really difficult to talk to. I mean, a real good example is, let's say you want to do something on gang violence. I mean, if you want to talk to people in gangs, that's difficult if you're coming from outside of that community. They likely wouldn't want to talk to you. So you have to think of some clever strategies in order to figure out how to engage those groups. And another issue is sometimes people have needs that you can't really have. There's not a sustainable or cost-effective enough program that you can actually fix it. I mean, the basic problem of poverty is a large problem, and you need more layers of government than maybe a local fund or a local grant can provide you to actually target it. So these are things you need to think about. So, I think where we go through this, we go through different phases of the community assessment. There's pre-assessment, where you basically do somewhat of an environmental scan. Who are the people that we need to talk to? Then you go through the process of gathering data. That's phase 2. And so then you start talking to those people that you need to talk to. And then there's a phase 3 post-assessment, where you essentially create a report where people, and you decide, okay, what kind of intervention, what do we need to do here? And so it's basically you give a conclusion. Oh, sorry, these are the 3 phases. I'm working with 2 different things. So as I said before, we have this pre-assessment where we basically figure out, we do an environmental scan, and then we talk to people at the next phase, and then at the end, give some sort of report. So does anyone know what assets are? If we want to do maybe a raise of hands, does anyone know what our assets are? So, I think in the 1990s, more and more community development researchers began to recognize that people who were going into communities, community development practitioners were coming into communities, and they usually had a really negative perspective of the communities. They would go in and they basically have this assumption that people are all there as victims of circumstances, and they're there to fix it. And the people there have no other reason to be there except just pure helplessness. There's not a recognition that these communities oftentimes have many interesting and exciting things going on in them that keeps people there. These can just be very strong neighborhood ties. It also can be that many of these people from these neighborhoods come from very, very large families that all still live in those neighborhoods. These are very important assets to think about while we're doing this kind of work, because these are what we can tap into to basically improve things in those communities. So what are some assets to think about? One is the skills, talents, and experiences of the people who live in those communities. There's also, businesses that are around, and people who are business people or who have leadership positions that live in those communities. This is oftentimes referred to as social capital in those areas, where you have people who have some sort of positions of power within the community who can influence change and improve conditions for those neighborhoods. And, and there's the most obvious thing that we oftentimes see. A lot of low-income, struggling neighborhoods don't have so many of these people with high social capital. And that's one of the reasons that we run into this problem. Other assets is that people that have a little bit of money they can donate, or gifts that they can give. Like somebody has a bus or something that they can provide for a mobile health station. There's also community levels. So any kind of institutions that exist in those neighborhoods, if they have schools, if they have healthcare institutions, if they have social service agencies, if community development agencies, that they have, housing that's available to people, libraries, parks, places people can meet, things like existing community networks that exist, that are around, that people can tap into. So, of course, we're also looking at needs. So when you're doing community needs assessment, you think of needs in several different ways. There's the needs relative to the standards, what is versus what we want, what things should be. And then there's, needs that are perceived by people, things that they individually think that they need versus really basic needs in order to ensure that somebody is healthy. And then there's other expressed needs based on behavior. So when people behave in a certain way, it expresses a need. Somebody smokes, expresses a need for interventions to treat nicotine addiction. And then there's relative needs. There's needs that, this community has versus what they have, those needs that another community have, like what a low-income community has relative to what a higher income community has. These needs also will be coming from the primary stakeholders, which are usually patients or consumers, in the case of healthcare organizations, and then secondary stakeholders. These are service providers, and tertiary are other types of people who partner with the organization, and then also resources and buildings and things like that. So there's many models. I'm just going to introduce one of the major ones, just to kind of give you an understanding of how these community assessments are kind of structured. So one of the ones that are used very commonly in health, among health professionals, is the PROCEED model. And the reason why that they like this model is because it incorporates multiple disciplines. One, there's a strong focus on health, public health, epidemiology, health administration, but they also will use social science and social work as well. That means that, and the acknowledgement that health and health risks are caused by multiple factors, and the efforts have to affect multidimensional and multi-sectory domains. So the way that these PROCEED model community assessments work is people do diagnoses based on these different multifactorial, multidimensional levels. So social, we would look at, income level, the most basic stuff. There's lots of census data that can be used to show social diagnosis for people. You can look at number of female-headed households. You can look at education levels, other things like that, employment statuses. Then there's also an epidemiological diagnosis, so we see prevalences of certain diseases or health conditions or other things like that, behavioral, environmental, educational, organizational diagnoses is where you look at how these educational and organizational systems are working, the culture and climate of them. And they also look at policy, and from looking at different systems where you see how a policy will affect people at the ground level. So I'm going to discuss a few of the tools that are oftentimes used, and I think they're kind of neat to show what they look like, because a lot of these tools used by community development and like urban planning and other public health professionals in this field they're used to provide a visual, because it's really important that people can kind of see what's going on. You can't just tell a story, you have to also make it visual to people. So one of the really exciting innovations for community development is GIS mapping applications, where we're able to map social, epidemiological, behavioral, environmental problems, and allow us to think about the interventions, how these factors affect the communities that we work in. What's also great about these mapping software is that it allows you to look at issues of access, availability, rates of problems in a visual format. And there's many different types of maps that can help you see these things in different ways. And we're going to go through a few of these maps. So the first one is a thematic map. And it's also referred to as a choropleth map. Use color and shading to depict values or select characteristics. It's good for covering larger sized areas like neighborhoods, block groups, counties, and it can compare different phenomena via darknesses of colors. What's really kind of cool about this is you can take these two maps side by side, and one is looking at the rate of people who have HIV diagnosis. That's the orange and black one. And the other one is looking at poverty status. So you can see this kind of correlation between poverty and the HIV status. And this is kind of what those CDC maps were showing, and that what people were really getting to see with life expectancy. Another really interesting thing that you can do with this maps is you can have point locations. So you can basically have, you can point out where all the healthcare centers are, or you can point out where all the places where people deal drugs are, or you can point out all the places where there's grocery stores in the community, or where you can buy cigarettes in the community. So it's kind of an exciting thing that you can do with it, and it helps you to really get a sense of different resources and different problems. You can also layer it on top of the thematic maps, and you kind of see that here, where they layer it on top. There's also something called dot density maps, and this can be something like you can look at populations, so you could see the density of a population in certain areas. But you can also say the density of poor people living in those areas, or the density of crimes in an area. I don't know if you've seen these before. This is, you may have seen a lot of these during the election where it showed the value of different electoral votes. You can basically resize counties based on how much prevalence it is to whatever exposure you have. So this one actually is focused on obesity exposure. And so you see that there's much more obesity in the sort of the eastern southeastern part of the US. It becomes much larger, as well as sort of the Midwest areas. Another interesting thing to visualize data or feedback from a community is concept mapping. This is different than geographical mapping, and there's many different types of software that helps you do concept mapping as well. This is a structured methodology for organizing ideas of a group or organization, and it helps groups to establish a framework to use for planning and analysis. Essentially, what it does is it helps you come to an agreement about what is most important. And it maps them out graphically so people can see them. So you see here, you have this map of different ideas, and you can't just kind of put them there randomly. You go through a series of steps to do concept mapping, and these series of steps are something that that is done in participation with the community. So the preparation step, that is essentially where you outline the goals of this process, and you outline the goals of what you're looking to achieve through meeting with the community. And then you also determine, you also prepare by recruiting people to be part of the stakeholder groups. The next is this idea generation. And the idea generation is when you get these groups of people together from different stakeholders and you have them brainstorm ideas around focal questions. So you have them figure out, like if you say, why aren't people going to the health appointments? And they would start listing transportation, they can't get there. And then you start listing those things, just brainstorming and adding every single one of them. So the next thing you do is structure. That means you basically sort and rate all these brainstorm ideas. Then you run, there's different statistical programs that will run a multi-level analysis to find out exactly where people are. But a lot of times people just kind of like sort and rate by hand and then come up with what they see as top priorities. And, then these are brought back to the community to interpret and discuss and process. And finally, they're used. And these are used, in a report to basically develop a program, other things like that. So these are some kind of neat concept maps. This one is, the establishment, and the interesting thing about these concept maps are you're kind of creating a framework. So it may look differently depending on how the discussion goes, how the brainstorm ideas go, how they fit together, what they mean in relationship with each other. But it gives the community an understanding of where it wants to go. There's transparency in the conversation. I mean, technically, we could do a concept map of how we do a community assessment. So here's a concept map of that. So another thing that is commonly used, this is also a type of community assessment that has been often used by hospitals and health centers. It is called the Community APGAR, and it's essentially used to figure out why they can't recruit the workforce they need. And but essentially it started in 1952, and it was a method of assessing the healthiness of newborn children. And the reason why it's been translated over into looking at into a sort of a community needs assessment is because of its simplicity. They use 5 criteria to measure healthiness of newborns. And that means that it can be done relatively quickly. So this is just basically, you know, a history of the community APGAR. You know, it basically in 2007, they basically decided to translate this test over into community to assess communities. And it basically started to be adopted more broadly in the US in 2011. And it's also been having some international use in 2015. And essentially, this is a validated tool to assess rural communities' assets and capabilities in recruiting and retaining family physicians. It basically is correlated with historic community-specific workforce trends. It also can be used to suggest factors more important for community to address when they have limited resources. And it's designed to be a real-time assessment tool. It provides guidance for interventions. These are basically the things that it measures. So it measures geographic factors in the community, you know, like if there's good schools there, if your spouse is going to be mad if you move there, you know, kinds of practices you can do, what kind of supports, organizational support that you have. If there's, you know, there's EMR records in your health facility, the list goes on. So, you know, also when you're doing community needs assessments, you know, I talked about earlier that sometimes you don't always have the data you want to have, but there is a lot of data out there to basically get a sense of what is going on in the community. Sometimes there has already been community needs assessments done by other organizations. Like I live in St. Louis City. I know that the St. Louis County Department of Public Health does a needs assessment every few years. The St. Louis County and city both do one. And they have a list of priorities that they focus on. You also can just do a literature review in the area. There's national level data. Census data is really good. The vital system data is basically vital statistics, birth, deaths. All that is available. The behavioral risk factor surveillance system is a really great data set focused on behavioral health and risk factors for like substance use disorder, you know, if you end up in an emergency room on the basis of a mental health problem, other factors like that. It also measures for there are some data sets within that surveillance system that focus on exposure to trauma. It's really exciting data set. There's also National Health Information Survey. CDC and SAMHSA have lots of data on many different things. We also have state level data. The State Health Department has its own data. State Department of Education, State Department of Justice, all these, they publish fact books. These all can be useful in what you're working on. At the local level, again, I talked about public health agencies, but there's also Chamber of Commerce a lot of times does these kind of assessments. There's regional planning offices that can provide data on a range of different things. Neighborhood leaders, hospitals. I mean, hospitals have their own EMR records that can be used to assess need. Social service agencies may have wait lists, so we show how much you know, people are the demand for different services. Here's some useful websites. I think that those are in your packet. And I'm just going to leave the floor open for any questions.
If anyone has any questions, feel free to chat them in or unmute your microphone and ask them.
You might want to turn your microphones on too, so that. Does anyone have any complaints? Anything else to say? Just a long afternoon of being tired?
Well, if no one has any questions, I'd just like to thank you for presenting today.
Yeah.
If I get any questions via email or anything, I'll send them your way.
Okay.
But we appreciate the lecture, and
Okay.
thanks for taking time out of your day to do it.
Yep. Thank you. All right. Bye-bye.
Thank you.
Bye-bye.